My name is Vic Calland and I'm the Medical Advisor to Patronus Rescue International Limited. On the training wing of Patronus Rescue, we want to provide you with the best means of helping the people who need you. We teach a wide range of skills, from teaching school children up to very specialist skills for advanced practitioners, and this talk is very definitely directed towards them. If you're just learning about resuscitation for the first time, please stick to the protocols and the flowcharts that the European Resuscitation Council and ILCOR produce. However, if you're experienced in resuscitation and you can handle cardiac arrest incidents with confidence, I'd like to offer you some thoughts that might get you to reevaluate the system of thought processes that you use. We all know the 5Hs and the 5Ts. Here they are. But I'm not going to explain each one to you. You should already be familiar with them. But in most flowcharts, they come quite low on the list. In this chart, for example, there are 3 episodes of CPR, each lasting 2 minutes, plus the time to provide 3 shocks. So effectively, it can be more than 6 minutes before you try to reverse a reversible cause. In some of these conditions, that's not a problem. Hypoxia will improve with your treatment anyway. Electrolyte imbalance, toxins and hypothermia will not deteriorate. And the therapeutic window for reperfusion of the myocardium following coronary thrombosis is wide enough to allow a small delay. But let's look at some of the others. In 4 of those reversible causes, the mechanism of cardiac arrest is that blood cannot circulate around the body. It doesn't matter if you do CPR, because the blood can't circulate. The brain is continuing to die from hypoxia. Your chest compressions are effectively valueless. Delaying 6 minutes before you consider reversible causes is the same as doing nothing. So what are those 4 causes? I hope you've already worked them out. In hypovolemia, there is effectively no blood to circulate. In pulmonary thrombosis, blood cannot get to the lungs because of the clot and therefore cannot circulate. In cardiac tamponade, the heart cannot fill and therefore cannot pump, and in tension pneumothorax, the pressure in the chest is collapsing the vena cava and no blood is returning to the heart. In pulmonary thrombosis, the outlook is dire. Thrombolytic therapy is theoretically possible, but looking at the time it takes to work and the problems of delivering it to the pulmonary artery when you have an obstructed circulation, such an approach will almost certainly be in vain. Myocardial rupture several days after a full-thickness infarct and post-traumatic aortic arch rupture both caused cardiac tamponade with no signs of penetrating wound. Neither are candidates for heroics, such as a clamshell thoracotomy, but if trained in the procedure and working as part of a properly resourced team, it is potentially an option for penetrating chest wounds, even in the pre-hospital environment. That leaves 2 more: hypovolemia and tension pneumothorax. Time and again in training I have heard candidates say, "There's no blood on the floor, so it's not hypovolemia." They ignore one of the 4 more, is the abdomen, and the possibility of hypovolemia secondary to a ruptured aortic aneurysm or ectopic pregnancy. Tension pneumothorax, secondary to asthma or emphysema, is also often forgotten. People think of it following chest trauma, and whilst this is a real cause, it's not the only one. So what's the answer? I would propose to you that as soon as you have initiated CPR and you have someone to help, ask yourself if it could be hypovolemia or tension pneumothorax. Try inflating the chest. If there is resistance, look for inequality of movement. But I have seen bilateral tension pneumothoraces, so if you have any doubt, Do a proper, effective thoracostomy. And I'll talk about that in another video. Check for the presence of a carotid pulse during chest compressions. Consider elevating the legs. It will auto-transfuse about a litre of blood into the core circulation and reduce the core circulation. See if you get a pulse back. I have successfully transported a AAA hypovolemic arrest survivor from church to operating theatre with his legs elevated on a pile of prayer cushions. If you get a pulse, then you know what to do next. Rapid transfusion. Now, I'm not telling you to change protocols, but now you've listened to this, perhaps you will think of just one H and one T right at the beginning of the arrest incident.